When you begin studying antibiotics, what's really hard is to figure out what antibiotic to use under what condition. At the very end of this lecture, we're going to review each of the different infectious disease diagnoses you're going to see a lot on medicine, and you're going to have to memorize their empiric coverage. And that's the problem. Most of the time, the antibiotic you pick is based on empiric evidence. It's really hard to derive which antibiotic you should choose. So for life, you're going to see a lot of the same things get used over and over and over again. On the test, though, they're going to expect you to know the usual antibiotics you're supposed to use for each of these diagnoses, but then they're going to throw in a wild card, some reason why they can't have that one, or it's going to sound like a regimen that's close, but really isn't. So we're going to start off by going through the antibiotic ladder, that is, how you might try to derive some antibiotic regimens based on the organism you're going after, realizing I'm not going to cover all antibiotics, and finish with the stuff you just have to memorize. So let's start off by going through gram-positive and gram-negatives first. And this is the antibiotic ladder. It begins with penicillin, so called the first antibiotic. And it was a good antibiotic. Had gram-positive coverage, gram-negative coverage. It worked. It was the first thing we had, and it saved a lot of lives. The problem with penicillin is, though, that most organisms have become resistant to penicillin, like Pen-V or Pen-VK, Pen-G or Pen-VK. And the only thing you're going to use penicillin to treat is essentially syphilis. So we've come up with other versions of penicillin. The first thing we attempted to tackle was Staph aureus. And we used the methicillins. Now, methicillin is not ever used in practice. It is in the lab only, and you'll probably have heard of MRSA, but we'll get to that in just a minute. These actually have a name, but I can call them the methicillins because they're used to treat one thing, and that is Staph aureus that is not methicillin resistant. Ox, clox, diclox, and NAF. Nafcillin is the one you're going to see used the most. Nafcillin is used for Staph aureus that is not resistant to methicillin. And since we're talking about it, the thing that comes up on the gram-positive column is MRSA, methicillin-resistant Staph aureus. You don't have to remember the diala thing, but just know that penicillin-binding proteins have changed such that regular penicillins don't work, and you need something special. And that something special is vancomycin. And I do want to take just a brief minute to talk about vancomycin. First, I want you to notice that vancomycin is not broad spectrum. It covers MRSA. When you pick vancomycin, you are saying, I'm treating MRSA. If you see MRSA, you should treat with vancomycin. It's in coagulase positive clusters. Is staph, you won't know that it's MRSA until it grows on the thing with the methicillin there, and it continues to grow, showing you that it's methicillin resistant. Oftentimes, MRSA is so prevalent, we start with MRSA coverage. On the test, be careful. They want you to go as far down the ladder as possible, starting with penicillin and working your way up. So if all you've got is Staph aureus, you probably want to pick a methicillin, unless you have a good indication for vancomycin. And this is the antibiotic ladder, so you want to start as low down on the rung as possible and climb your way up only as necessary. So if you can't use vancomycin for whatever reason, going off the top of the ladder is linezolid. And linezolid is a really good choice. It's got an oral form and an IV form, but it is really expensive. So the most important thing about this ladder is that you should not start at the top of the ladder. You should start as low down as possible. For MRSA, it's going to be vancomycin, and then linezolid if vanc's not available. On the gram-negative side, we have some penicillin variants, and that's ampicillin and amoxicillin. Now, you may be frustrated by this because amoxicillin, you can use to treat strep throats, and strep throats are treating strep. Yet, I'm going to tell you that amoxicillin and ampicillin should be used for gram-negative coverage. If you're going after organisms that are gram-negative, you should go for amox and ampicillin. And the way you get, without empirics, the way you get these expanded to get a little more coverage is with the beta-lactamase inhibitor. This makes them broad spectrum. They have gram-positive, gram-negative, but notice they don't touch MRSA. Ampicillin's the IV, amoxicillin's the PO, amoxicillin, clavulanate, ampicillin, sulbactam give you broad spectrum. But that's not broad enough, because just as there was MRSA on the positive side, so too do we have a resistant virulent organism on the gram-negative side, and that is Pseudomonas. To treat Pseudomonas, you need a stronger version of penicillin, and that's going to be piperacillin. There's another one in here, but I never use it, so piperacillin is the one you want to remember. And it's beta-lactamase inhibitor. Tazobactam. Pip/Tazo is Zosyn, and Zosyn is used all the time in the hospital. It's used all the time in the hospital because it has gram-positive, gram-negative, and anaerobic coverage. The only thing it doesn't get is MRSA and fungus. So if you just have to reach for something because you don't know what's going on and they're sick, you put them on Pip/Tazo. And that's okay in that situation where they're really sick and you don't know what the bug is, because you're going after everything, because if you don't treat it, they'll die. But really what you're saying is, when you say, I want Pip/Tazo, you're covering Pseudomonas. If you're not going to cover Pseudomonas specifically, don't reach for Pip/Tazo, pick something else. And very similarly to linezolid, if you need more coverage, well, they can't take penicillin, carbapenems. Carbapenems are very good gram-negative coverage. They also cover Pseudomonas. And this lies to you a little bit more than usual, and that is to say that Pip/Tazo and carbapenems are essentially the same on the ladder, but I want you to realize that people are going to reach for Pip/Tazo much more often than they are carbapenems. So in this world of gram-positive and gram-negatives, there's one last piece, and that is the cephalosporins, the foundation on which this ladder is built. And I'm being very particular about where I'm placing these blocks, because I want you to see that third-generation cephalosporins are going to grab gram-positive and gram-negative. All right. If we map out gram-positive coverage, you'll see the first and second generation cephalosporins have a lot of gram-positive coverage and begins to taper off in the third, and you essentially should not use fourth generation cephalosporins for gram-positive coverage. And then the exact opposite is true for gram-negative coverage. There's very little in the first two generations. The third generations begin to pick it up, and the fourth generation cephalosporins are essentially the things you use to cover Pseudomonas when you can't cover anything else. Ceftaz and ceftriaxone, third generation cephalosporins, cefepime, fourth generation cephalosporins, and the ones over here you very rarely use. These are going to be skin antibiotics like cefazolin used to treat cellulitis and do prophylaxis for surgery. Ceftriaxone and Ceftaz are going to have good penetration, gram-positive and gram-negative coverage. Fourth generation cephalosporins, cefepime, should be used only for Pseudomonas. Now, I want you to know that there is a fifth generation cephalosporin, but you're not going to use it because it's MRSA coverage and it's way off the ladder. You're never going to use that until you actually get the cultures and sensitivities. That's really important. So we pointed out MRSA and Pseudomonas, and so we're going to pick those things for empiric coverage of diseases that might be caused by these bugs. In general, what you want to do is be as targeted as possible. If you get a culture, then you have sensitivities and you pick the narrowest spectrum antibiotic, the cheapest one. In addition, if someone's really sick, just go broad, which is why everybody gets Pip/Tazo and vancomycin when they're sepsis and they're really sick. You're getting everything. So that's okay. Escalate quickly, de-escalate slowly, and if they're ill, go broad. At the end of the day, be as narrow spectrum as you can based on cultures and sensitivities, but it's okay to start off broad. But if antibiotics were this simple, you wouldn't need the video. So there's a little bit more. There's also the fluoroquinolones, which I want to talk about. And I like to use the baseball mnemonic. That is to say, in baseball, you have to go through first base to get to second, to get to third, to come home, so that anyone on third base has already gone through first and second base. That is to say, the correlation of the fluoroquinolone generations, the first generations have their unique properties. The second generation includes the properties of the first generation because you had to go through first base. And likewise, the third generation fluoroquinolones possess the second and first because they had to go around the diamond in order to get there. Now, you've probably heard people mention the respiratory fluoroquinolone or the urinary fluoroquinolone. Well, I got news for you. The entire cardiac output goes through the lungs. So every fluoroquinolone is a respiratory fluoroquinolone. And most of the excretion is done by the urinary system. So every fluoroquinolone is a urinary fluoroquinolone. So what are they talking about when they say that? What they're talking about is this. It has to do with the gram-negative and gram-positive coverage. The first generation fluoroquinolone is ciprofloxacin. And Cipro has great gram-negative coverage, but it doesn't do anything for gram-positives. And since Cipro is the urinary fluoroquinolone, you might not be surprised to realize that urinary tract infections are primarily gram-negative. The third generation fluoroquinolone is moxifloxacin. And moxifloxacin, being a third generation cephalosporin, has gram-negative coverage. But it also picks up some gram-positive coverage the others don't. Moxifloxacin can be used to treat pneumonias, the respiratory fluoroquinolone, because it is capable of covering the organisms that cause pneumonia. And the second generation I don't ever really use. That's levofloxacin, some adjunct soft skin tissue infections. But what I want you to see is the fluoroquinolones, Moxi should be used for treating pneumonias. Cipro should be used for treating gram-negative infections. Whereas Moxi can cover gram-negatives, but you don't want to give the unnecessary coverage, so stick with the lowest on the ladder, in this case, the lowest on the baseball diamond. Anaerobes you can get with Piptazo, but you sometimes want to be more targeted than that. And this is my advanced organizer for remembering what to use where. You've got two options, metronidazole and clindamycin. Metronidazole is groin and belly, abdomen, vagina, groin, belly, metronidazole only. If it's anywhere else, clindamycin. If you want anaerobic coverage, clindamycin for anywhere not the belly or the groin. Metronidazole if you're going after anaerobic coverage for the vagina and in the abdomen. Now there's definitely more to it than this. Now it's more complicated than this, and we're not going to talk about a lot of things. We're not talking about fungus, and we're not talking about some other antibiotics that you'll come across that I just don't use that often. The reason why I'm doing that is to keep this simple, because you're going to pull these antibiotics often in order to get the right answer. So let's go through, as I said I would, the empiric coverage for the diseases you're going to see the most often. It's going to be community-acquired pneumonia, healthcare-associated pneumonia, meningitis, UTI, and cellulitis. For a community-acquired pneumonia, you have a couple of options. We've already talked about it. The first one is Moxi. Moxifloxacin can be given oral or IV, and so it's very tempting to use Moxi because you're given IV first, you have an oral equivalent right away. But you're going to breed fluoroquinolone resistance to certain organisms, so if you can avoid that, avoid it. You can also use ceftriaxone and azithromycin. We didn't talk about the macrolides, but you should memorize ceftriaxone and azithromycin, or Moxi, or azithro on its own. It goes something like this. If the person's going to come into the hospital and needs IV medications, you should give them a combination of ceftriaxone and azithromycin. If the person is ambulatory and can go home, just give them oral azithromycin. Moxi is the equivalent for ceftriaxone and azithromycin, so it can be given IV or PO. Moxifloxacin ends up being abused by physicians in the sense that it is poor antibiotic stewardship, so for the test, it is always wrong. In an HCAP, you're covering for two things. You're covering for MRSA and Pseudomonas. Knowing that, the logical choice is going to be Vanc and Piptazo. Meningitis, just have to memorize it. It's ceftriaxone at 2 grams, a higher dose than usual. Vancomycin, plus minus steroids, plus minus ampicillin. For the M3 level, every meningitis gets steroids. For the M3 level, only immunocompromised patients get ampicillin. More on that in the brain inflammation lecture. But it's ceftriaxone and vancomycin and steroids and only ampicillin if you have immunocompromise. For UTI, you've got a couple of options, and this gets frustrating. Amoxicillin is good, as we said, gram-negative coverage. Or you can use nitrofurantoin. Or you can use Bactrim, trimethoprim sulfa. Or you can use ceftriaxone. Or you can use Cipro. So how do you pick? Amoxicillin if you're pregnant, nitrofurantoin if you're a woman, Bactrim only if you don't have renal failure. Ceftriaxone is IV, so it's given to people who are septic with really bad pyelo, and Cipro is reserved for ambulatory pyelonephritis. You're going to see this misused all the time, but that's the test answer. Cipro is only used for ambulatory pyelo. Ceftriaxone is used for inpatient management of pyelonephritis. These others can be used essentially interchangeably, unless you have renal failure, where you can't use trimethoprim sulfa, unless you're pregnant, where you should use amoxicillin as the first-line answer. And encephalitis becomes really tough because there's a lot of outpatient, inpatient management. But what I want you to learn is the cellulitis that you suspect to be MRSA. Since we want MRSA coverage, we should use vancomycin. But other options exist because this requires intravenous forms. You can also use Clinda or Bactrim, knowing that it is not unreasonable to treat with a first or second generation cephalosporin going after strep and then only using these guys when it's failed because then it's probably MRSA. Okay, let's go through it one more time. Antibiotic ladder, stay as low as you possibly can. Look out for nafcillin, vancomycin, linezolid for staph coverage. Look for ampicillin or amoxicillin for gram-negatives and pip/tazo for Pseudomonas. Carbapenems, also Pseudomonas. Cefepime, fourth generation cephalosporin, also Pseudomonas. Clindamycin everywhere else, metronidazole, gut and groin. And then you just have to memorize the list of antibiotics that go with each condition and kind of know a little bit about why you can't choose one over the other. And that is the antibiotic ladder.